2025 has been a big year for psychedelic science. We've seen cutting-edge research papers, lots of patient advocacy work, and an ever-growing interest in psychedelic medicine. I've only been doing this podcast since about the spring, and I've learned so much and had so many great conversations, and I think it's time to shed some light on the amazing institution that has made this all possible, the Center for Psychedelics Health Research. Hello, and welcome to the last episode of the year of the integration session. I'm Dr. Elena Koning, and in this episode, I'm joined by a very special guest, Dr. Claudio Soares, Director of the Center for Psychedelics Health and Research at Queen's University and Providence Care Hospital. You're going to hear a little bit about Claudio's background, his vision for CPHR, what the center has accomplished so far this year, including insight into our 2 clinical trials, and what he has planned for 2026. Let's get into it. Hello, Claudio, and welcome to the Integration Session podcast. Thank you so much for being here.
Hi, Elena. Very nice to be here. Very excited.
Awesome. So let's dive into a bit about yourself. So I'd love to know more about your background in psychiatry and how you became the lead of the Center for Psychedelics Health and Research at Providence Care and Queen's University.
Sure. Just maybe as an introduction, my relationship with psychedelics is relatively recent. So I trained as a psychiatrist many years ago in my native country in Brazil. And then I decided to do a postdoctoral fellowship in US. So I lived in US for 6 years. And at that point in time, I was working more in women's mental health and looking at the connections between estrogen and depression. I lived there for 6 years, and then I moved to Canada. It's been probably 20 years or so. Always working this interface between psychiatry and the medical field. One of the areas that I end up working in the past probably 10 years is oncology and palliative care. And that's probably where I start getting some, connections with and understanding maybe the role of psychedelics in mental health. I saw a lot of patients struggling with depression and anxiety, having demoralization or existential distress. And the data and the clinical work on psychedelics was just emerging at that point in time. So then I ended up connecting with the Queen's, emerging Queen's Research Center, and that was happening here. People are getting interested in understanding more psychedelics, more from a cultural, ethical, and knowledge synthesis point of view, not much from the clinical trial perspective. But that's how I ended up connecting. And then over the past several years, this research just blossomed at Queen's, and we are fortunate to have support to open the center, which I'm sure we're going to be talking about today.
Yes, yeah, exactly. Thank you for that background. It's so interesting to hear about how people end up in this field, and it always is related to patients and sort of that patient-centered
Absolutely.
motivation. So could you walk us through the history of CPHR from how it originally started and sort of its origins in the Queen's Psychedelic Research Collaborative to its official opening, and then also what makes it unique as one of Canada's first comprehensive centers for psychedelic science and education in healthcare?
Absolutely. So probably I would say we have to go back to 2021 for that. So Queen's Queen's University, where I am now, received some support to open a advisory group to look at, or a collaborative to look at psychedelics in a more comprehensive way. And that was led by David Clements and Ron Shore back then. They were really empowered by the university to start looking at psychedelics and psychedelic research or psychedelic science from the perspective of maybe policy making and also public awareness. I think the original design or desire from Queen's was to really be a hub where people could look at psychedelics from different angles and understanding maybe the cultural and ethical issues related to psychedelics. One of the creators, one of the founders of that research group was David Clements, as I mentioned before. David has a strong background in policy. He worked in the cannabis environment before. So he knew a lot of the challenges that were ahead of us to bring psychedelics to the mainstream. So that group evolved, and I was invited to be part of it. And I was one of the few clinical trialists that was interested in psychedelics here at Queens. There's a lot of people interested, as I mentioned before, in knowledge translation, knowledge dissemination, but not a lot of people with the clinical trial experience. So I became fascinated, to be honest, with a lot of opportunities in clinical research in psychedelics that were happening outside Canada. But Canada was actually well positioned to do clinical trials, and they are just starting to happen at that point in time. So from that initial collaborative, we evolved into expanding the collaborative to be more clinically oriented, and then opportunities for clinical trials happen. We ended up doing the first clinical trial at Queens with psilocybin for alcohol use disorder. We started building capacity here. And then we decided to really expand it to be a more hub for interdisciplinary and multidisciplinary research on psychedelics. We are fortunate to get some support from Providence Care, the Providence Care Hospital, which is now the institution that hosts the center, and the Ontario Brain Institute, the OBI. They are really behind us and really support the idea of creating a comprehensive psychedelic hub. So what is unique, you asked me what is unique about CPHR, is that it's not a person's lab. It's not dedicated to my area of research or anyone else's area of research. We are really a hub, a catalyst for research in psychedelics. So that's the first thing. The second thing is that we are not really only focused on mental health. We are really looking at different approaches or different uses of psychedelic agents. So we have people from the pain field, people interested in pain management, cancer, oncology, palliative care, we have nursing, we have historians, we have really, really multidisciplinary and also multi-professional. So I think the facts that we are not one person's lab, but also really multidisciplinary are really unique to, at least as far as I know, unique in Canada.
Yeah, definitely. It's been really cool to see the center sort of emerge, and I'm super grateful to be a part of that.
Well, you're so excited to have you in here.
Yeah, and another question actually just popped to mind because you were speaking about your background in psychiatry, but from my understanding, you also have an MBA.
Yeah, I
So
do.
how does that how did that help you in this role as director for the center?
Yeah, so the MBA is actually a funny story because if you asked me probably many, many years ago if I ever imagined pursuing a master's degree in business, I would say absolutely not. I have always been fascinated with science and medicine, but I noticed over the years that we actually, physicians, lack a lot of soft skills that we need in terms of sometimes they're not that soft. I don't think accounting is a soft skill. It's a tough one, but it's a lot of skills that we need when we actually building interactions, whether with our patients or institutions, when we're trying to do fundraising or when we work with corporations. There's a lot of skills that you can learn in business or business management that can help physicians to build their practice, but also to build relationships and to be productive, right? So one of the things that I did over the last several years, I was a department chair or department head at Queens for psychiatry for almost 7 years. And in my leading up to leadership positions, which I had a few in my career, I always noticed that, project management, HR issues, even accounting, which I don't necessarily like as much, are skills that we can learn. And that helped me to have a more kind of entrepreneurial vision of how to establish things or new enterprises. And that I think has been a asset in my role. It helped me to understand how to pitch new ideas to corporations or foundations. I think helped me to have a vision of how to establish a new center and try to explain that in a way that would be enticing to the founders or to the sponsors to support the center. So yeah, I think the MBA has been an asset that I kind of surprisingly is being effective to build a psychedelic center in a non-for-profit institution. Yeah.
Yeah, definitely. Yeah, I think it's an interesting piece of your background, and it definitely shines through in how that sort of benefits you and how it's allowed you to succeed in this role. And we'll get into the clinical trials, like you mentioned a little bit earlier. But first, in the spirit of this being the last episode of 2025, I would like to look back a little bit and just reflect on the year. So, what would you highlight as the key achievements for CPHR this year? And that could be like milestones or notable achievements. What comes to mind for you there?
This has been a very, very busy, very productive, and I'll say very rewarding year for us here at CPHR. Um, I I could probably point it out a few things that I thought were, really important this year. But one thing that comes to my mind, which I was so pleased, was our annual meeting that we had not too long ago, when we had a chance to bring all the close collaborators of the CPHR, the so-called the founders of CPHR, people who have been working in CPHR from the beginning, including you and others, and people who are interested in researching psychedelics, people who have been in the field or in the margins of the field, but really flirting with the idea of working in psychedelics. We brought almost 40 people, I think it was 35 or 40 people that spent with us a full day, and it was a very busy, a very productive day when we went through all the accomplishments of the center, but also all brand new ideas. We did a little bit of strategic planning for the center, and I think that really consolidated us as and one thing that we did was actually we went through all the things that we said we would be doing in our first year, and we're so pleased to see that we accomplished probably 95% of them. And one of the things that we were hoping to accomplish was exactly having that meeting to consolidate the center. So having the annual meeting as the first of our scientific meetings, I think was a milestone. And the other milestone is, I think, is really, or milestones, we're having quite a few clinical trials up and running, which shows our capacity to, not only design, but also implement and execute clinical trials. I think that's probably the two clinical and organizational points of view. But I have to tell you, one thing that is a major accomplishment is what we're doing right now, is the integration session podcast. That fantastic to have that, and have so many people saying that they actually listen to the podcast or learn about our center through the podcast. So that's definitely made the highlight list for 2025.
Oh, well, I'm glad. Yeah, it's been a pleasure, and it was great to be at the meeting. You could really sense the sort of collaboration and all the inspiring things that people are working on. It was a really cool thing to be a part of. And yeah, let's get into the clinical trials now. So, the
Right.
first one I want to talk about is microdosing psilocybin for generalized anxiety disorder. So, what is the scientific rationale for testing microdosing psilocybin for this indication? And how does the evidence from different types of studies, so preclinical or smaller studies, support the idea that a low dose, non hallucinogenic dose of psilocybin could be helpful?
Yeah, so I'll tell you that our decision to enter to the microdosing world had a healthy dose of skepticism. I would say if you are as I know you are, because you are also a researcher, when we look at the bulk of research, of the body of research in psychedelics, probably 90% have been on high doses or macro doses. Very little research, although it's emerging now, but very little research on low dose, no hallucinogenic doses of psychedelics in general, including psilocybin. So, one thing is why are people not interested in microdosing, and I think a lot of that comes from the probably a few things. One is the fact that a lot of the research done in the past with microdosing has been driven by surveys in healthy volunteers. that describe usually wonderful things, but these are people who chose to use microdosing on a open label. They're not really controlled studies, but also most of them are healthy volunteers or people who have not been diagnosed with mental illness or depression, anxiety. So I think that discouraged people to pursue microdosing studies. And the other thing is, I think, is a school of thought that believe that you need really the maybe the underlying biological changes that happen in a macrodose to have the benefits of the pharmacological benefits and the psychological benefits of psilocybin. There's probably some skepticism and not a lot of clinical data suggesting that microdosing could be effective. But when you look at the structural, the molecule from the structural point of view, right, being a serotonergic agent, and there is no reason to believe that lower doses could not be beneficial. We just don't know exactly what dose and to what degree it could be beneficial. So this particular psilocybin use that we have in our clinical trial, they have done phase one trials. They look at a dose-dependent healthy volunteers, and they look at safety, and then also the threshold for perceptual changes. And they found out that between 2 to 3 milligrams was the dose when you start having, for some or for the majority of healthy volunteers, changes in perception of self, of the environment. So we know the dosing, but we didn't know exactly the potential benefits for patients with depression and anxiety. We chose anxiety together with the makers of the psilocybin because of the potential effect on rumination and reappraisal of behaviors. So the idea that low doses could actually, because of the serotonergic effects, reduce some of the anxiety and ruminative thoughts that we see in patients with anxiety, it felt like this could be a potential benefit clinically for patients with generalized anxiety disorder, which is by nature worrying too much, right? People who are constantly worried and constantly worry about things that they have very little control over it. And that leads to always ruminating the worst case scenario or catastrophizing things. So the mechanism of action and the potential benefits of the low dose actually matches better, if you think about it, for anxiety than for depression. So that's why we decided to try first for generalized anxiety disorder. But I will tell you that over the last probably a couple of years, we have seen this explosion of studies on microdosing now. Our colleagues from Johns Hopkins are doing studies on traumatic brain injury, mild cognitive impairment. There are people using for reduction in opioid use or opioid withdrawal. There's people interested in also benefits for depression, maybe as an adjunctive treatment. So there's a lot of growing interest in microdosing, but I think it, for us, was really the culmination of let's try to study something with a little bit of skepticism, but also not stay on the sidelines and really do research on an area that most people are trying to avoid.
Mm-hmm. Yeah, certainly a really interesting and important indication. And this is Canada's first sort of Health Canada approved phase 2 study for at-home microdosing.
Yeah.
So I think what's really interesting about this as well is that macrodosing studies can take a lot of resources and are very intensive in terms of the time required from highly qualified professionals. And microdosing allows for the at-home sort of therapeutic aspect, which I think is so interesting. So can you describe the design of the trial? So what is the dose actually like, the duration, who is actually the participants taking these? They obviously have anxiety disorder, but what else is important to know? And how does this differ from the traditional macrodosing psychedelic studies?
Sure. So yes, you're right. So this study is the first study that we are aware of that use psilocybin delivered at home. There are other colleagues, including some colleagues from Ottawa, they are doing microdosing studies on psilocybin for different indications, for instance, for demoralization and cancer patients, but they're all receiving the medication in the hospital or or they are actually having the medication shipped to them under control, very controlled use. So this study is the first one that people can take the medication, bring it home, and they have weekly visits to be reassessed. So the way that this study was designed, so this is a phase 2 trial. So phase 2 trials are by design smaller trials. They're really focused on looking at safety and tolerability. They're also looking at efficacy, and we are definitely looking at efficacy in that study. But you also want to make sure that people can take psilocybin at home safely, and they can tolerate using the dose at home. And it's also daily use psilocybin, which is new. A lot of people have used psilocybin microdoses, taking days off, or maybe using 3 or 4 days a week to avoid what has been described as tachyphylaxis, that they do create a habituation to the use of psilocybin. So one of the things that we're interested in is to really show that potentially there is no tachyphylaxis for a dose of psilocybin for anxiety. So the way that the study is designed is that we expect to have 60 participants in that study. We're almost halfway. We're almost with 30 already included. But people come and they do a series of physical and emotional testing to make sure that they are healthy otherwise, but they have to meet criteria for at least moderate generalized anxiety disorders. They cannot have any other major psychiatric illnesses. They may have depressive symptoms, but not necessarily major depressive disorder or psychosis as their primary psychiatric illness. So really focus on people who have moderate to severe anxiety, but otherwise relatively healthy. So they come to the study, and then after a series of physical and psychological testing, they use the first dose of psilocybin, which is 3 milligrams in an oral solution. They use that with us in the hospital, and they stay here for the first dose for 4 hours. And during that time, we had a chance to really observe how they react, if they had any physical or emotional unusual reactions or side effects, including altered states of consciousness or changes in perception of self or the environment, because we want to make sure they will be able to take medication at home, right? Mm-hmm. So in very, very few occasions we had to repeat that dose or bring someone for a second dose because they had an unusually altered experience in the first dose. So once we know that they are ready to go, so they take 1 week's worth of medication home, and they use the medication at home every day, and then they come back to the hospital on a weekly basis when we reassess them, make sure that they were able to tolerate the medication used daily, and then they take another supply for another 7 days and take it home. So really trusting our patients to bring the medication for 7 days and use just 1 dose daily for 7 days. Then after 4 weeks, when we find out who's a responder to psilocybin, they are randomized to another 4 weeks when they either continue on medication or they switch to placebo. So the second part of the study, which also lasts for 4 weeks, it's a double-blind phase. And it was designed to see if all the benefits that they had as an open label will continue in a double-blind fashion for 4 weeks. But also to see if those were randomized to placebo, if they still benefit from the medication beyond 4 weeks, or if they develop, for instance, any discontinuation symptoms, or even the reemergency of anxiety, as someone would describe with vengeance, right? So you want to know if people can remain well after responding well to 4 weeks. Mm. And I think that a lot of that came also from the literature on microdosing, right? So we know that sometimes people use 1 or 2 high doses of psilocybin, and their antidepressant benefits, they sustain over time, right? So you want to know whether the benefits of psilocybin for anxiety in a much lower dose will also sustain over time, even after they discontinue the medication.
Yeah, that's so interesting. And yeah, you mentioned 30 participants have gone through the trial so far.
Yeah, we almost 30. We had quite a few. We had a few dropouts, people who couldn't tolerate medication for different reasons. We also have. We had to adjust our schedule because of suppliers issues, but also because we had to make sure that we had enough infrastructure to have a constant flow of new subjects. So we probably at the very early, probably by January or February next year, 2026, we're gonna have at least 15 or 20 people who completed the first 4 weeks, and were either completers but not responders. So then for that study's done, or completers and responders that enter the double-blind phase. So I'm anticipating that the whole study will be done by the summer of 2026, which is quite fast for a new trial. So we're excited because then hopefully that will inform a larger trial, right? So we're going to learn a lot about that study, including the dosing, but also the population that tend to tolerate better, or maybe we need some dose adjustments for people who have a lower BMI. So we are hopefully learning a lot from the phase 2 and help us to design a phase 3 trial as well.
Yeah. And are there any early insights that you can share in terms of the results, or is it just too early to tell?
Well, I would say we have to be cautious with our enthusiasm. This is an open label study, right? So everybody knows that they are taking, and we know they are taking psilocybin in the first 4 weeks. So we take that with great assault because we know that in studies in general and psychedelics, even more important, the expectation is a huge component. So if you add that to the fact it's an open trial, I would say you have to get a great discount at what we see in the first 4 weeks. Having said that, the time to respond and the magnitude of response that I have seen in some of those cases is really surprising me, to be honest. I've done in my career probably more than 30 clinical trials and probably at least more than a dozen open trials. So I'm used to see patients responding well to medications in an open trial, whether antidepressants or sometimes combination behavioral activation or behavioral interventions with medication. But the degree to which some of those patients responded to psilocybin and the type of response, the symptoms that they describe, that they feel more physically relaxed, or in some cases that they can concentrate and they feel sharper because the anxiety is no longer an obstacle for them to function. And that may happen in 1 or 2 weeks. I haven't seen that in open trials with antidepressants. So the quality and the magnitude of response, I would say, are the key surprises so far. And there are also a few side effects that we are still learning, who can tolerate better, who cannot. So it's been actually quite fun to do that clinical trial.
Yeah, I look forward to seeing the results. It's exciting. Okay, so moving on to the second one, which is also a really interesting trial that CPHR is doing. So this involves an interesting formulation of DMT designed for rapid onset for treatment-resistant depression. So what led CPHR to explore DMT specifically for depression? And how does this short duration acting formulation compare to other psychedelics? And why might that be useful?
Yeah, so our involvement with GMT is an interesting one because I would say I have always kind of quite intrigued by GMT, not because of the DMT, synthetic DMT, but because of the millennial and multicultural use of ayahuasca. I mean, I'm originally from Brazil. Ayahuasca is huge in South America as a medicine that is used culturally and religious ceremonies, and it has a deep-rooted tradition in medicine there. And one of the major, probably one of the great researchers in ayahuasca, Draulio Araújo, is also from Brazil, has done a lot of studies on vaporized DMT. So So I was being always fascinated by ayahuasca, and also talking to my colleagues, including Ron Shore, and others. The potential use of ayahuasca has always been great, but in my mind, I always thought it would be very, very difficult to bring ayahuasca to the mainstream, and for different reasons. One is out of respect from the traditions that are surrounding the use of ayahuasca, and the rituals and ceremonies that have been traditionally related to the use of ayahuasca outside the medical field. So it'll be very hard to replicate or to appropriate that in the medical field. So I always been like, this be out of sight for us, and probably out of touch for the medical field. So when I learned that there was an opportunity to look at a active compound of ayahuasca, but also in a way that could probably cause less of a side effects from the medical perspective, that was quite intriguing. And it's interesting that what is considered actually part of the ceremony with ayahuasca, which is the purging, in the medical field, you can imagine is perceived as a side effect, right? Mm-hmm. So one of the challenges is how to really make that transition from the use of ayahuasca outside the medical field to the medical field. And this particular way of delivering DMT, I think it's a potential breakthrough, because it is, as you mentioned before, is just a intrabuccal film that allows that to be dissolved very quickly within 20 to 30 minutes, and minimizes all the GI, the gastrointestinal potential side effects of ayahuasca, but also minimize or reducing the hallucinogenic effects that you may have. So it's probably a lighter version of what you have when you use, certainly much lighter or less intense than you use ayahuasca outside the medical field. But even within the options of using DMT, including the studies on vaporized or intranasal, the expectation is that DMT delivered through that mucosa or intrabuccal film would be less intense. So we were approached by an international company who was doing that study as a potential Canadian site, and we became quite interested. It's a very complex study from the logistical point of view, because it's a multinational study. And it's also a study that includes a lot of safety measurements that we have to do with international groups to make sure that patients are or participants are eligible. So from the operational point of view and logistical point of view, it's quite of a major task for the center to get involved. But it's been interesting, and we are still in the early stages. We're still bringing people through screening, and we haven't had one dosing session yet, but we have one potentially scheduled for early next year.
Exciting, yeah. And what does you spoke about it being an international operation, but at CPHR, what does the study design look like?
So basically, this study is designed for patients with treatment-resistant depression. So they have to have a history of not responding to antidepressants. One of the challenges is that this is not an add-on study. In other words, we're not adding DMT to the existing pharmacological treatments that they have. So although they are patients with treatment-resistant depression, they have to be off medication to be able to enter the study. So one challenge is, as you can imagine, is to find a patient that has been treatment-resistant, tried multiple antidepressants, and failed to respond, and agrees to come off of everything and be off medication to then enter a study that initially is a randomized controlled trial, placebo-controlled trial, for 16 weeks. So they come to the study off medication. They're randomized to receive either DMT or placebo. Then after 4 weeks, they have a second dose, again, either placebo or DMT. Then they are followed for 12 weeks. And then after 12 weeks, everybody has a chance to have a dosing open label. Mm-hmm. So there is probably an incentive to come to, at some point, you're going to be able to receive medication. But there is a randomized placebo control design that I would say on one hand is exciting because we're going to learn if the medication works, but from the participant and patient's perspective, um, it's a tough one because they might be, they obviously have a depression has affected their lives, and they have to be willing and able to potentially remain off medication and without having an active treatment for up to 3 months. So that has been one of the challenges to find the right candidates, but also criteria and eligibility from the medical perspective. There's a lot of things that we need to check from blood work and AKGs and everything else to make sure that they are otherwise healthy for the study.
Yeah, sounds like quite a few challenges there, but I'm confident that you'll be able to pull it off.
Yeah, no, it's been also a learning curve for us to see how psychedelic research trials are happening in the larger scale. They are, I mean, research in Canada for psychedelics, and I think it's quite it's booming, and there's probably 3 or 4 places where a lot of research is happening. But it's also interesting to see how researchers in other places are approaching psychedelic science and clinical trials. And the opportunity to be part of a multinational trial also allow us to be in touch with other centers and other people doing research on psychedelics as well.
Yeah, definitely. So, yeah, so up to now, we've talked about the past, we've talked about your background, CPHR, we've talked about what's going on right now at the center. So now I want to look to the future. So, 2026, as we move into the new year, what are the top priorities for CPHR, and how do you see the results of these clinical trials shaping its future directions?
Sure. Well, we're going to be busy in 2026. So 2026 looks very promising to us. I'm probably going to highlight a few things that I'm quite excited about it. So from the knowledge translation and engagement, I think we're going to continue to support this awesome podcast that you have, and really want to expand that and have, think about different guests and different areas that you haven't had a chance to explore yet, and probably or hopefully have more people helping you to support that to expand podcasts. I think we also want to move to engage communities in different ways, maybe doing some town halls, opportunities to engage publics, maybe have some sort of a scientific but also fun debates on issues that we know are dear to people's interest in, and might be a way to also tackle some of the misinformation or myths and realities about psychedelics. There's a lot of like almost everything in science, there's a lot of a noise out there of psychedelics are ready for prime time or they're not, are they legal, they're not, microdosing versus macrodosing. So I think there's a lot of things that could be approached by members of the center or guests in a kind of a fun way to engage the lay public. So we're going to be doing that, but also we have this partnership with CanPact, which is this great network that has been established for psilocybin therapy for cancer patients. And part of our role within that collaboration with CanPact is developing educational modules and informing not only healthcare professionals but researchers and trainees. So I'm really excited about this area of the CPHR to grow. It's like our involvement in education and training. We have plans to develop, for instance, a scope review on educational materials or trainings that are out there, but also information for communities. Developing maybe a module on psychopharmacology of psychedelics. So a lot of things happening on the knowledge translation education. But also clinical trials. We have probably 2 or 3 new clinical trials that are coming to the center with collaborators that we have, tackling use of psilocybin for depression in women with a history of childhood abuse or maltreatment. We have a colleague who's bringing a study on psilocybin plus calm therapy for patients with late-stage cancer. And we're also going to be collaborating and to develop a pilot trial for CanPact for for psilocybin mindfulness. So we're going to be busy, but it sounds like a very productive year, both in the clinical but also educational point of view as well.
Yeah, definitely. It's been great to chat with you today about all of this and sort of breaking down the center. And I know it's not been a focus of previous episodes, so it's been really great to do that. And yeah, I'm just looking forward to what next year has to offer. So thank you so much for doing this,
Oh,
Claudio.
my pleasure. Thanks for having me, Elena. And
Yeah.
I'm a huge fan of your podcast.
Oh, thank you. Thank you so much for supporting the podcast this year, and we look forward to many more amazing conversations about psychedelic science in 2026. I'd like to thank the Center for Psychedelics Health and Research at Queen's University and the support of our sponsors at the Ontario Brain Institute, the Canadian Biomarker Integration Network in Depression, and Providence Care Hospital. Happy holidays, and until next time, be well and integrate wisely.